Good evening, everyone. Thank you for joining us. We are going to get started in just a moment. We've got a really big group with us this evening, so we want to make sure that everyone has the opportunity to log on and find us here on Zoom. You are in the right place, though, and we will get started right at about 6:30. So thanks for your patience. If you're just joining, we're going to get started in just a minute. You've found the right place, and we've got a big group this evening, so we want to make sure that everyone has the opportunity to log on successfully via Zoom. But thanks for spending your evening with us, and we'll get started in just a moment. All right. Good evening, everyone, and thank you so much for joining our Men's Health webinar. We're so excited to have the opportunity to share important men's health education with this group tonight. My name is Brittany Conan, and I am the host of tonight's event. I'm going to start with a couple housekeeping items, and then I'll turn it over to our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the speaker. We do encourage interactive presentations. So if you'd like to ask a question, just type it in the chat box. It's at the lower part of your screen, and then we'll save time at the end of the presentation to answer as many questions as we can. Tonight's webinar will be presented by Dr. Adam Childs, who is a prosthetic urologist and a men's health specialist at Arkansas Urology. Dr. Childs, I know your time is in high demand, and I thank you for your willingness to be with us this evening to share education with the community. I'll turn it over to you.
Thank you, Brittany. Well, I'd like to welcome everybody out, and I appreciate y'all making a little bit of time to learn a little bit more about some men's health issues. These are things we're very passionate about and things that are obviously very personal, but something that we can also help with. So we're going to spend a lot of time going through this and then some time answering questions. And I'll just kind of remind everybody that this is going to be recorded and it should be available online somewhere, I believe, through the Arkansas Urology website ultimately. And so as I go through some of these slides, I may be moving a little bit quick and some of them are a little bit dense and I won't spend a lot of time on them, but they'll be available for your review if you go back and watch them later. I'm going to pause on this screen for just a minute. This may be a good one to take a picture of or to scan the QR code, but this will link you guys to some information that'll be helpful, some good resources essentially online where you can go over this in a lot of detail as well. I'll give you just a minute to capture that. And again, this will be available later as well, but if you want it now, now's your chance. Okay. All right. Well, a little bit about me. I practiced at Arkansas Urology, been in Northwest Arkansas for quite a while now, 12 or 13 years, and did medical school in Houston and then trained in urology at Mayo Clinic. And just a few little things about me here, I guess, on the bio, but we love all things urology. We're going to start with erectile dysfunction this evening. We're going to learn a little bit about it, some of the issues that drive it, some things like that. Then we're going to talk about some of the treatments. But ED is a very, very common issue. I see a big spectrum of men who are maybe getting older, but also a lot of young men who suffer from this. And it's estimated or felt that probably about 1 in 5 men above age 20 at some point suffers from ED in these younger ages. And as you get to be older, meaning over the age of 40, it's estimated that over half. And I find that when guys come to see me, it's usually a more significant situation, but this means, you know, things not being as good as they used to be. So a lot of guys kind of suffer with this for a long time before they break down and come see us. So I just want to stress it's very common, certainly something we can help with. From a basic anatomy standpoint, what happens with erections is when you get stimulated or aroused, the nerves activate some things with the blood supply in the penis. You essentially get more blood supply in, and that helps trap blood in these specialized veins that keep it from leaving the penis, and that's how you go from flaccid to erect. And so there's a few steps in this process that can go wrong, leading to this phenomenon of erectile dysfunction. And there's a lot of things that are associated with erectile dysfunction, certainly more common with age, certainly more common with smoking. We see a lot of erectile dysfunction and diabetes, but also other very common conditions like high blood pressure, high cholesterol issues, and then we see it in issues that are very common, including obesity, depression, other lifestyle issues like sedentary lifestyle, side effects to other medicines, those sorts of things. And so quite a few different causes, and honestly, a lot of my patients have multiple things working against them when it comes to erectile dysfunction. So this is certainly a physical and medical issue, but also a deeply psychological issue that affects a lot of health and well-being. So a lot of guys who deal with ED can experience a lot of psychological health issues: anxiety, depression, low self-esteem, loss of self-confidence, decrease in quality of life, and they can oftentimes tend to withdraw from their partner from an emotional and physical standpoint. And so there's a lot of ramifications when guys choose to not deal with this issue. And so the good news is there's a lot of options out there that we're going to get to, and I'm just going to hit some of the common things that we see in terms of patterns in erectile dysfunction. First up is ED and diabetes, and these two go hand in hand. Unfortunately, I will see some younger men with complaints of ED who haven't been seeing the doctor, who we end up diagnosing with diabetes. It can oftentimes be the presenting symptoms. We also find that with our patients with diabetes, that ED tends to be a lot less responsive to oral medicines and other treatments. So it's definitely something that comes with challenges. Certainly some things that we can heal, but unique to some of the other causes of erectile dysfunction. The big issue here is it's kind of hitting you from two angles. One is with chronically high blood sugars and diabetes, it affects both nerves and blood vessels. Both of these things are very important for erections. Things like ED pills require the nerves to be stimulated. So if there's an issue with nerves, that does not work well, but they also require a certain amount of blood supply. And if the blood vessels are not working normally, either the arterial supply or the way the veins trap blood, both of which are affected with diabetes, will have issues. So that's probably, the big reason why, diabetic types of ED can be a little bit more challenging, as we're working against some significant issues. There's also some other factors, in men with diabetes that that make ED worse. Diabetes is more common when you're older. How long you've had diabetes can affect it, meaning the severity of the disease state, how well it's controlled, meaning that, when we have men who are not taking their diabetic conditions seriously and have chronically high levels, they're kind of silently having these things occur where there's damage to blood vessels and nerves, and by the time they're ready to take care of it, it's sometimes too late. Diabetes can lead to other forms of vascular disease. Some of the other treatments related to diuretic treatment can also increase risk of diabetes, and that's probably maybe more of an observation, not so much the drugs, but the fact that as diabetes gets worse and it affects other things in your body, you end up being put on some of these diuretic treatments, and that signals a more severe case of diabetes. And then heart disease, which we're going to talk about here in a minute, is much more common among men who are diabetic. And when there's issues with heart disease and blood supply to the heart, it's usually preceded by years and the blood vessels going to the penis. So those two go hand in hand as well. So that leads us to that point of ED and heart disease. Symptoms of heart disease oftentimes develop within a few years of having erectile dysfunction. And we'll show you a slide here in a minute that kind of helps you understand that cause. Those two go hand in hand. They're both essentially vascular diseases. And they've seen in a lot of people who've suffered heart attacks or coronary artery disease, oftentimes they had erectile dysfunction in the years preceding that they either know about or they weren't addressing. So it definitely is the canary in the coal mine when you look at penile health. Can be a big signal of how your overall health is. When we look at this issue, this is a diagram we'd mentioned here, but it shows the size of these different arteries. And if you notice at the bottom of the screen, the penile artery is fairly small, 1 to 2 millimeters. Compare that to the artery supplying the heart, which are 3 to 4 millimeters. And so as you have this process that leads to heart disease, where these plaques build up and there starts to be blood supply issues, it tends to affect the penis first before it affects the heart. And a lot of my patients who've dealt with heart attacks and heart disease, some of them have got more severe vascular disease processes leading to issues in this internal carotid artery, which is in the neck, and this femoral artery, which goes to the leg, what's called peripheral vascular disease. And those are all essentially similar processes, even though they have different names. They're all caused by the same factors. It's just that with the penile artery being smaller, it is the first one that gets affected. All the things that help your heart help your penis. And so we always hit these things in some detail when guys come in to see us, but we recommend a heart healthy diet. We recommend physical exercise, certainly losing weight. All these things your general doc and your heart doctor would want you to do, like stop smoking and limit alcohol and avoid illegal drugs, are all things that apply to um, the penile situation. And also stress. I'm not sure we understand that perfectly, but stress has been linked to an increased risk of vascular disease. And so there's something there that's helping to drive inflammation in the body that promotes this. And so if I ever have a young man who comes in and he's not seeing the doctor and he's just here to see me, for ED, I'm recommending those men get a primary care doctor and get looked over head to toe and get up-to-date cardiovascular screening. So there's a definitely connection there. And then as we look at other factors that go hand in hand, ED and low testosterone. And so that's something that's very common in our clinic. Low testosterone is a very common phenomenon that happens as men get older. Guys tend to have their peak testosterone levels in their 20s, and then it tends to be all downhill after that. But it can certainly be associated with other things besides age, including obesity, lifestyle in terms of a lot of processed food or a lot of calories, type 2 diabetes, obstructive sleep apnea, and even other medical conditions that affect the kidneys, the liver, and other things like HIV. And so there's a lot that can drive low testosterone issues, but there's no doubt there's a lot more erectile dysfunction in that group. And as we work through treating erectile dysfunction, we're oftentimes checking low testosterone levels pretty early in the process and addressing that along with the vascular and nerve issues that come into play with erectile dysfunction. Low T has a lot of symptoms, most commonly low libido, low energy levels, erections not being as good as they used to be, but can be a lot of other things like hot flashes and depression and difficulties with concentration and memory and all sorts of things. So quite a few things, but it's definitely a very common men's health issue that needs to be addressed. That's probably underassessed and undertreated in the primary care setting. But I think as a specialty, over the last couple of decades, it's really become very clear how important this is, and it's gotten a lot more common to treat this with notable benefits to patients. A lot of options for low testosterone. We have patients do a lot of testosterone injections, but there's topicals, there's actually oral medicines, there's pellet implants, pills you can take. So there's quite a few options. And so at the end of the day, it's a fairly easy thing to treat. All right, very common in our practice. We do a lot of prostate cancer, but is erectile dysfunction and prostate cancer. Any man who's been through prostate cancer and has had to treat that disease can have ramifications on both urinary function that we'll talk about later, but also sexual functions. We talk a lot about these things before, and we have a lot of expertise in treating this just because it's part of the survivorship of prostate cancer. And essentially, the issue here is both nerves going to the penis, but also blood supply. And so we try to protect those things with treatment, but invariably there can be some degree of damage. And so there can be a spectrum of complete loss of function to partial loss of function that requires treatment to address afterwards. That can be short term as things heal, but can also be long term. And this slide kind of demonstrates the act of prostate removal, which is where the prostate gland circled there is removed from the bladder and the pelvic floor, and things are reconnected to the urethra there. But what's not shown are some important nerves for erection that are attached to the prostate that we tend to try to spare when we can when doing these surgeries. There's different numbers we'll see out there, and I think different numbers that get quoted. But at the end of the day, I try to tell guys that most guys will have some effect on their sexual function. Our hope is to get them back to functional afterwards, typically within a year. And they may be functional, but I try to stress to them that it may not be as good as it was before. And again, it can be a near complete loss to as good as it was before for some guys, but usually everybody's somewhere in between. And so there's some different numbers quoted out here, and it's not clear in the study how they exactly define the severity of ED, but it is a common survivorship issue, regardless of how the treatment was done or whether a patient had surgery or radiation. Another common condition that is associated with ED is something called Peyronie's disease. This is the curvature of the penis. I've seen a lot more commercials for this the last 5 or 10 years, advertising some of the products that are out there, but this is also something we see quite a bit of. These two go hand in hand, meaning the vast majority of my men with Peyronie's disease, uh, it really is precipitated by erectile dysfunction. I just think that they're prone to develop these fibrous plaques in the penis. And essentially what happens is they have a process that starts probably because of some mild to moderate ED where they get these plaques, and it changes the curve of the penis to just about any direction you can imagine. Certainly a very debilitating process for men, very frustrating process. There's a lot we can do about it. But one of the big things we do immediately is address the ED to prevent things from getting worse. It's not a cancer, it's a benign process, but it certainly can cause a lot of intimate issues. There's a lot of different treatments for Peyronie's disease. We're not going to cover them in detail tonight, but we typically do some conservative things with oral medicines. There's potentially injections into the plaque that can break it up, and there's also even surgery. But I will note here that when guys have Peyronie's disease and ED, very good option is a penile implant that we're going to talk about tonight. And so when there's kind of more moderate to severe ED, especially if things are not responding, we're more likely to bring up this idea of penile implant in this scenario because of the curvature issue. So, yeah, this is pretty much what that says, is that there's options there, and these two go, essentially hand in hand. All right, let's get into these treatment options. And so as we look at treatment options, there's a lot of people who can treat this, right? Sometimes this conversation starts in the primary care office. Most of the primary care doctors I know and have worked with are usually pretty comfortable with the basic medicines and the lifestyle counseling. It doesn't always happen. Sometimes it gets sent right to us, which is fine, but sometimes these things have been exhausted when guys come to see us for second and third line treatments. All urologists are very familiar with this and should be fairly experienced in the spectrum of treatment options. They may not all offer the full spectrum like we do. Some urologists go and do additional training in what's called prosthetic urology, or just focus on kind of like ED issues. And so they won't do prostate cancer or kidney stones or enlarged prostate, but they'll try to just focus on these conditions only. And so not all urologists are familiar with everything we're going to talk about tonight. Many are. I think it just depends on where they train and what their interests and comfort are. But there are also people who focus exclusively on the things that we're talking about tonight. Here is a slide I oftentimes show patients in my clinic that kind of really hits all the things that we know work for erectile dysfunction. So we certainly are interested in the causes of it, and we certainly talk about the lifestyle changes and any mental health support that can be of benefit. But regardless of the cause, whether it's a nerve issue, a blood supply issue, any of those things, whether it's from diabetes or heart disease, we typically trial these oral medicines. And these are things that most of my patients are familiar with, things like generic Viagra, generic Cialis. Those are the two most common we use. There's a few other ones out there that aren't generic, but they all generally work in similar manners. There's vacuum erection devices that we'll go over, what's called penile injection therapy, and penile implants. So I think we have some slides on each of these in a little more detail after this one. We always promote a good, healthy lifestyle. Again, by the time guys come to see me and things are more advanced, we can't always fix it with this, but when we have more mild to moderate ED, we can typically fix it with some of these things, including healthy lifestyle changes. If there's any psychogenic component, sometimes there's therapy that can help there. Sometimes testosterone can help too. So not everything is starting with just pills. When you look at the pill option, I think these are generally tolerated well, especially things like tadalafil, your Viagra and sildenafil can work very good, but we see a few more issues with them, like headache, facial flushing, upset stomach. There are definitely some patients who can't take these pills because of other medicines, typically what are called nitrate medicines. But generally, this works pretty good in kind of moderate to some severe cases of ED. Can work for years, can certainly not work at all. So sometimes if I have a diabetic who has not had an erection in years and he's coming to us to finally address it, it's not necessarily surprising if this doesn't work if they've got a more severe picture. Okay. We always mention this idea of vacuum erection device, and if you look at the process here, you essentially use this vacuum tube to create suction on the penis that pulls blood into the penis manually. If all you did with it was this vacuum tube and you take it off, it goes away right away. So you have to use some sort of compression band to trap the blood in there. And so this can allow you to penetrate a partner, but it's also something that's not very enjoyable for guys. It's kind of uncomfortable for them. Doesn't have the highest satisfaction rates. I honestly don't have a lot of patients using this, but we mention it. And I find that my patients who use this tend to be older, tend to be less sexually active, only having intercourse a handful of times per year. But this can be a reasonable solution for some individuals. For guys who fail pills, I usually encourage them to try penile injection therapy. This essentially is a small shot into the side of the penis of a medicine that we call Trimix. There are a lot of different versions of this out there. There's single drug agents, there's a double drug agent we call Bimix, and the triple drug agent we call Trimix. Has 3 different things in it. But these medicines are all designed to improve blood supply to the penis, help trap blood in the penis, and help you have an erection. But they're all delivered by a needle. And so there's a little bit of education we have to do on this. There's certainly a little bit of encouragement I have to give to guys to try this because nobody's real thrilled about the idea of a needle in their penis. Typically it goes pretty good, but there can be some issues like penile pain. There can be concerns for prolonged erection. So we typically train people how to do this in clinic and do a test dose in clinic to make sure they don't overshoot. But when you start it, you have to kind of titrate up from a low dose to high dose, trying to get to an erection that's hard enough to penetrate and last long enough, but too long becomes a problem. Over time, with repetitive injections, you can cause scar tissue in there. We've even seen people have some bleeding where they get a bruise or what's called a hematoma at the injection site. We don't see that as often anymore with the small needles we're using, but back when I first started training, the needles were a little bit bigger and it was definitely more of an issue back then. Okay. But there are definitely people who stop this treatment because they just don't like it. They don't like the issue of the medicine having to be refrigerated. It's definitely hard on single guys in terms of spontaneity. It makes it hard to travel. So there's definitely some big inconvenience. The needle can be a mood killer for guys. So some guys just psychologically don't do well, with the idea of running to the refrigerator and grabbing their needle and their Trimix or their medicine here. Cost wise isn't too bad, but can definitely add up depending on how much you're using it. Definitely more expensive than Viagra and Tadalafil. Not the worst expense out there, but definitely if you're a regular user, it adds up over time. So at the end of the day, some people fail this with time where it stops working. Some people kind of give up on it out of frustration. And so there definitely are studies that show some decent withdrawal rates or discontinuing rates after guys have started this, even when it seemed to work at the beginning. And so anytime we're kind of starting to fail pills, we're certainly talking about penile implant as an option. I do encourage guys to try the injections because you never know how well it's going to go or how they like it. But at the end of the day, if injections don't work, if guys are not happy with injections, we have a serious talk about the penile implant. And we're going to spend a little bit of time on what this is, a few different versions of it. But essentially, this allows a man to have a normal anatomical erection. Essentially, it's an inflatable device inside of you that you can activate and pump up on your own, or your partner can activate. It's a fairly simple procedure to do, a little bit of recovery in terms of bruising and swelling. But at the end of the day, although there's a little bit of healing that has to go on and a small risk of a few complications we're going to mention, most people are very happy with the results and would do it again and would recommend it to a friend. As we look a little bit more at these implants, it's not quite like buying a car where there's a million models and things like that, but there's definitely a few different things out here. On the right, you have what's called a malleable penile prosthesis. This is one that doesn't inflate, but you can bend it up and bend it down. This might be an option for someone with limited hand function or for an older couple where hand dexterity is going to be an issue. Traditionally, we have done the AMS 700, this one on the left, with what's called an MS pump. For a long time, this was the only inflatable pump available. But recently, Boston Scientific has released this newer model, the AMS 700, with a Tenaccio pump. And this is a very nice device. It's a much easier pump. We've, for the most part, gone exclusively to using this because there's really not a reason not to use it. But as we've gotten some experience under our belt with it, it's a much easier pump to learn how to use. It's much easier to squeeze, and I think it's going to make these older ones kind of disappear fairly quickly just because it's a big, it's a big improvement in an already good product. So we call this a three-piece inflatable penile prosthesis, and we're going to show you a little bit more about it. Essentially, we put it in through a small incision at the base of the penis where we can put these different components in, what's called a fluid reservoir, the control pump, and then the cylinders. And this is all internal. So the control pump kind of sits in the scrotum like a small third testicle. It's nothing that's noticeable from across the room. But when you activate it, you essentially pump it to fill these cylinders to get a natural erection. The whole device is coated in a product called inhibisome, which is an antibiotic coating, which has been shown to help decrease infections, which is the greatest concern that any prosthetic doctor like myself has about putting these in, because if these things get infected, they ultimately have to be removed and nobody's happy, and you just don't do as good when we go in there to put another one in as if it would have worked the first time. But fortunately, infections are rare, but we do everything we can, including use this product with inhibisone to help minimize that. Okay. At the end of the day, this is not a new product. These things have been around a long time. And so there's a lot of experience with these, and a lot of them have been put in patients, and they've gotten better and better every decade in terms of the quality and the nature of the device, and they're going to continue to get better with time as I hear about newer things in development that are coming down the road. Here's a video of how this device works in action. So you'll see this model essentially inflate the device and deflate the device. I'm going to go ahead and click on this video and let you guys watch this for just a minute. It's a little bit of a slow start, but as it goes through this, the animation will start here in just a minute. How many pumps a patient does depends on the size of the device and how inflated it was at baseline, but most people have to put a good number of pumps in, but essentially they pump and move fluid through the device into the empty cylinders. When they're done with the active intercourse, there's a little release button there that they push, and it automatically deflates and refills that fluid reservoir. There's sometimes a little bit of training on how to use this, but most patients pick it up pretty quickly, and typically we release them to be sexually active after the healing process about 4 to 6 weeks later, typically 6 weeks. Okay, let's see if we go to the next slide here. It's a little bit of delay on going to the next slide, I think. So give it just a minute. There we go. All right, so when we talk about the implant, we do this as an outpatient procedure. It typically takes us about an hour and a half to 2 hours. There's a few different versions of this device, but ultimately what I tell patients is I want to put in the one that we think is best for you, that you're going to be happiest with, and that can depend on intraoperative measurements in terms of a couple different things. But at the end of the day, we're typically very happy with the device that gets selected. It's done under general anesthesia. We do leave a catheter overnight and everything's kind of wrapped up, and that usually gets unwrapped and catheter out the next day. We do leave the device partially inflated for a couple weeks to kind of stretch things. And then early on in the healing process, we have you cycle the device where you inflate it and deflate it to promote healing and to kind of stretch the tissues. But typically, as you go through that healing process, most guys are only on pain pills for a couple days. Most guys are a little bit bruised and swollen for maybe a couple weeks, but I'd say most guys are looking pretty decent in a couple weeks afterwards. And I'm usually giving guys the A-OK to cut loose on the device at about 6 weeks afterwards. We get a lot of questions about cost and coverage. Fortunately, those are typically not real big hurdles. This little page kind of just goes over the nuances of saying, well, not every insurance might cover it, and maybe not every Medicare plan covers it, but generally, I find that 99% of men who want one of these devices is able to have insurance coverage, whether it's commercial insurance plan or Medicare. Medicare does cover this, and so we see very little issue with Medicare, and the only insurance plans I feel like I've seen issues with are technically not full kind of, federally what they call Obamacare rated plans. They're kind of more just catastrophe insurance plans that exclude a lot of things, including erectile dysfunction treatment. So at the end of the day, guys can certainly pay cash for this, but the reality is most guys don't. And this little link down here can give you an idea of what cost might look like for you if you get into the details and look at your insurance plan. At the end of the day, this is a very effective, successful option for guys. 97% of people would recommend it to a friend. 95% of patients report satisfaction. And when I talk to guys who do voice some dissatisfaction, I think some of it's expectation management, meaning that they expected everything to be like it was 18 again, when really it's not quite that, but they're still ultimately pretty happy. It certainly gets the job done in terms of restoring traditional intercourse. And so it's a very good option. I do prefer Boston Scientific products over others, and one of the reasons being is this antibiotic impregnation of the tissue. I think we really believe that that helps decrease infections. Okay. Fortunately, this is typically a once in a lifetime thing for guys. These devices are very durable. When we look down the road, 10 years down the road, the vast majority of them are still functional in the range of things like 90%. But I also tell guys it's kind of like a new car. You can occasionally get a lemon that has an issue that breaks down a little bit sooner. It's also like a car in the sense you put 100,000 miles on it, you might need to have it replaced sooner. But most of the replacements that I've done in my career have been over 15 years out from when they did that, with a couple of exceptions of some that have just randomly not worked early on, but that tends to be a small percentage of the replacements that we end up doing. So they're very durable, and for most guys, once in a lifetime thing. But if I ever have a younger diabetic who's 45 or 50 in this situation, I do have to really talk to him about that scenario, because he's probably going to have it replaced down the road at some point. It's just a question of whether it's 10 years or 20 years or longer. At the end of the day, this is a very discreet very discreet option for guys. And I've had a number of single guys over the years who just are not going to do injections because of the situation on their dating scene. And so this is a very good option where they can be sexually active in a natural way without other people knowing that they really have one of these. If you feel closely, you can kind of say, hey, something's maybe there or something's different. But for the most part, during the active intercourse, it just feels like a very good erection. Does not interfere with ejaculation or orgasm, allows spontaneity. And so at the end of the day, this really is a superior option for treating erectile dysfunction, certainly for guys who don't like shots or fail shots, but it really is worth considering doing this as an alternative to shots. As discussed a little bit earlier, there's always some risk to surgery. No one can guarantee the future. The main thing I worry about is a very small risk of infection, which I really believe is 0.4% or less. So we see very, very few infections, but I promise you we do quite a bit to minimize that risk. I always try to manage expectations and really kind of educating guys on what this is, what the details of the recovery are. I've had some guys over the years who didn't have as good a hand strength as we thought they did, and had some issues operating the device. And there's usually some things that we can do about that. Every once in a while, as we mentioned, there'll be a mechanical failure early on, or there'll be an issue with it kind of automatically inflating, and those can be addressed simply by replacing the device. Not that that's something anyone's excited about, but that fixes the issue, and it's not too difficult to go through that. I've also had a few of these devices migrate a little bit. Most commonly, that reservoir can sometimes shift and pop back out of the abdomen if it's not quite up where it needs to be, or if someone develops a hernia. And so occasionally there has to be a little bit of revision there to address an issue. But at the end of the day, most guys do not have to go have anything else done. They're typically happy with the results that they get. Okay. Many years down the road, the device can erode through the tissue. And the few times that I've seen this in my career, it typically involves somebody in a nursing home who had a catheter in, who was not really getting good care, where there was kind of constant pressure on the tips of the cylinder. The thing was partially inflated. No one deflated it or knew what to do with it. And so I think a lot of those issues are largely preventable by doing a good job at the beginning, and then just making sure that people are educated about that long term, so that if things come to that at the end of life, that somebody's watching for issues there, that they're at least keeping the device decently deflated. All right, this is a very common thing, as we mentioned earlier, but I appreciate you guys coming to learn a little bit more about it. Check out this website, edcure.com, and at the end of the day, this is a lot of our practice is helping men with this issue, and the good news is there's a lot of things we can do to help them out. And And these are just a few pages I'm going to fly through here that are just kind of disclosure safety things about both the AMS 700, which is the inflatable, and the malleable implant. Okay. All right, we're going to shift gears here. So I'm going to pause on this screen for a minute. This is next part of the presentation is going to focus on um, fixing incontinence. Essentially, we're going to talk about male stress incontinence or some other types of incontinence that are pertinent that we're not going to discuss today, but this is more going to focus on what's called stress urinary incontinence, which most often comes after prostate cancer surgery, but can come from some other things as we'll talk about. But there's also other forms of incontinence that guys have called urge incontinence or overactive bladder. So if someone ever comes to see me for incontinence, we're figuring out pretty quick which of these two it is. But tonight we're going to focus a little bit more on the male stress urinary incontinence situation. All right, so let's learn about this. We're going to jump right into this, but essentially what is it? This is incontinence that happens when you move, cough, sneeze, bend a certain way, causing you some leak. That's why they call it stress incontinence. Something stresses the muscle down there, the abdomen. And so we'll have guys who are dry most time, but they do a certain maneuver and they have some leakage of urine. That's called stress incontinence. And this can come from a lot of different conditions. They estimate 13 million men across the world suffer from this condition for one reason or another. And in the United States, 17,000 men per year, start to have this issue. So this is a common thing that we see in the urology clinic. This slide kind of shows a little bit of the anatomy, shows the bladder, shows the urine that leaves the urethra through the prostate, shows the sphincter muscle and the male urethra. And essentially, the key here is that pelvic floor muscle, the sphincter muscle, is quite important for controlling urine, as is the prostate, what's called the bladder neck. And these are things that we try to spare during surgery, but we know that there are some men who rely a bit more on the prostate muscles that have to come out with surgery. So even when we spare the muscles, which I think we're very good at sparing the sphincter and the bladder neck, we know that there's some men who are going to have some issues after surgery. So as we look at this, most common cause of stress incontinence in men is removal of the prostate, but other things can cause it. Radiation of that area, pelvic fracture, other urologic surgeries, most classically some sort of TURP surgery like a green light laser surgery or traditional TURP surgery. We see it in neurogenic conditions where something happens with those nerves and the muscles and they just don't work the way they're supposed to. And we can certainly see it from other pelvic surgeries for non-urologic organs, things that affect the rectum, like rectal cancer, anal cancer, anything down in the pelvic area. Okay. We've even seen it after urethral surgeries, for men who have complex reconstructions, usually related to stricture disease or previous pelvic fracture. All right, so one study has shown that men suffering with urinary incontinence have higher chances of depression than those without. This is definitely true. And I try to talk to guys about this heading into prostate cancer treatment. Again, nobody can predict the future for them individually. And so I try to explain to them that, we'll have guys, a lot of guys who are going to be very good in this regard and never have a lot of issues. Other guys that take a year to get better, but there are guys who deal with this long term. And I've had guys have leakage. It's a couple pads per day and honestly don't seem too bothered by it and don't want to do anything about it. I've had other guys who are in a state of depression from it. And when I try to get into the details of it with them, they ultimately tell me they're not even wearing a pad. So they're dealing with a small amount of leakage, not enough to wear a pad, but it's been psychologically debilitating for them. So there's a big spectrum of how guys handle this, but it definitely is something that affects our quality of life, affects their mental health and just their social health and social aspects of life. So at this point, we're going to talk a little bit about male stress urinary incontinence and prostate cancer. And so when you look at some of the statistics here, there's 90,000 prostatectomies done per year in the US for prostate cancer. And you'll read some different numbers out there. This is kind of a ballpark. They say 9 to 16% have some sort of leakage a year afterwards. I think some of those numbers are lower for young, healthier men, but I actually quote higher numbers for men getting older and with certain health conditions. So I really try to customize my predictions for my patients based on my experience, what I've seen, what I'm seeing with the patient in terms of their health issues. But when they look at big studies across the country, these are, this is a number that gets quoted. At the end of the day, what's happening here, as we showed you earlier for the other slide, you remove the prostate and we're trying to preserve the bladder neck and the urethral sphincter. you sew those together, and that's why men have a catheter in for about a week afterwards when they have a robotic surgery. And no matter how good your surgeon is, you're losing some of that prostate, which can be important for urinary control. So I tell everybody that, look, you're going to have some leakage afterwards. It's going to be more than you thought it was, more frustrating than you thought it was. But for most people, it gets better, but it takes months to get better. But if you don't have a good surgical procedure, that sphincter can be damaged. You can damage that bladder neck. And so there's a lot of different reasons why guys get the spectrum of stress urinary incontinence. At the end of the day, there's fortunately some options for this, right? And we kind of hit all these options early on just to help speed the general recovery process, but these can be options for guys with leakage down the road. But there's certainly behavioral changes where drinking less fluid and planning bathroom breaks helps. I'm a big proponent of pelvic floor physical therapy, so I try to get everybody there before surgery, but also afterwards. If I remember seeing a guy for a second opinion who has this for any reason, we have some decent success with these physical therapy interventions. There's certainly for guys with more severe incontinence, things like pads and diapers and catheters like condom catheters or penile clamps, and those things can work and help with, clothing issues and sheet issues in terms of wet linens, but they're not ideal, especially for more active men who are more independent, those sorts of things. And so we're going to go over a few options, and really the two big options that are out there for male stress incontinence are either what's called an Advanz male sling system or an artificial urinary sphincter. So we're going to talk about the sling system first. Essentially, this is indicated for mild to moderate stress urinary incontinence. So to me, that means, a pad to a couple pads per day, but not soaking pads, not a dozen pads per day. It's done as an outpatient procedure. Essentially, it's a mesh sling that you put in that helps support the urethra. You don't have to do anything to operate it. It either just works or it doesn't work, and generally has a fairly high success rate. One study showed a reduction of pad use by 77%. So again, I think managing expectations is very important here, because if someone wants this and they're 4 pads per day, we may not be able to get them totally out of pads, but that patient may be very happy if they go from 4 pads a day to 1 pad a day. Whereas the patient with 1 pad a day, the expectation is to be out of pads. So this can work for a lot of people, but it's not the best option for everybody. Not always the best option when there's been a history of radiation. Essentially, what this is a mesh sling that gets put in through some small incisions that goes in at the base of the pelvic floor at what we call the bulb of the urethra, or the bulb of the penis, and it acts to kind of um, lift up the pelvic floor to help the sphincter essentially work better, so it's not under as much stress when you cough or sneeze and that pelvic floor moves. At the end of the day, 88% of patients in a study of 79 patients would recommend this to a friend. So most patients have a very positive experience with it. And I think there was a slide, maybe I missed it, or maybe it's not in here. Maybe it's from one of the old presentations. I apologize, but it shows a different view where it's actually lifting up the tissue. So it can definitely work. And I've definitely had some patients who are happy with this, but also there can be some issues where it doesn't meet expectations. I've heard of patients having some discomfort from it long term, or just some irritation. So definitely some things to be aware of heading into this. I'm a little bit more of a fan of what's called the AMS 800 artificial urinary sphincter. This is definitely the gold standard for all versions of incontinence. Certainly the option I recommend if guys have more incontinence, typically more than 2 to 3 pads a day or higher volumes of incontinence. This essentially is what it says it is. It's an artificial urinary sphincter. And so we're going to show you some pictures of this and how it works, but it was designed to treat male stress incontinence following prostate surgery. It's used in some other situations besides just prostate cancer. But it works for all these different conditions of male stress urinary incontinence. And the way it works is it mimics your healthy sphincter by maintaining pressure around the urethra when your bladder's filling, and then you operate it when it's time to empty your bladder. You hit a button, it relaxes, you drain your bladder, and then it automatically reinfills or refills. Does require you to have some cognitive ability and some manual dexterity. So we always have to talk to people about, well, what happens as you get older with these things? Because if you can't use it, someone's going to have to use it for you, or we're going to have to do something. And typically what we do is we just deactivate the device. And when we do that, you go back to how things were before the device, where you just kind of go back to leaking urine, which usually is sufficient. So these can work very, very good. At the end of the day, what it is essentially like a three-piece device where you've got a balloon that we call pressure regulating balloon that holds pressure in the device. a control pump that goes in the scrotum, and then the cuff that goes around the urethra. And this is typically put in through two small incisions, one behind the testicles and one up above the pubic bone. The whole procedure probably takes us an hour and a half. It's done as an outpatient procedure. You typically have a catheter in for just a day or two. We do leave the device deactivated for about 6 weeks to let swelling go down and let everything heal. And then we typically activate them at 6 weeks. And at that point, we find out how well it works pretty quickly. And typically it works very well in terms of getting guys out of pads, or for guys who are completely incontinent, wearing a lot of pads gets them into a safety pad or something like that. So it works very, very well. I believe we have a video here, so I'm going to hit this video. And like the other video, it's a little bit slow to start, but essentially it's going to demonstrate how this device works. But essentially it's just one or two squeezes on the device. Fluid moves out of the cuff that they're going to show you into the pressure balloon, and that allows you to pass urine. Then as you're walking away from the toilet, it automatically inflates. So this is pretty simple, and it's usually just one or two pumps is all people have to do. And as they're walking away from the toilet, this thing inflates and starts to act like your normal sphincter again. So pretty simple. All right, as I mentioned earlier, outpatient procedure, a few small incisions, and most of us wait at least 4 to 6 weeks to activate it. I'm kind of a 6 week guy, is how I was trained and what I like to do, just to kind of make sure that really things are healed up and that people are going to be ready to use these devices. At the end of the day, very high satisfaction on these devices. Over 90% of people report long-term satisfaction. Over 90% of people would get it again. 94%, believe it or not, would recommend it to a friend or family member with the same condition. And you'll see some different numbers on success rate, but these things remain very successful down the road. And so they just quote a couple different studies here of people wearing one pad or no pads after receiving these things, and they're fairly high rates at 6+ years down the road. Like the P&L implant, they're mechanical devices. So occasionally you get a lemon that breaks down where we have to go replace a component or replace the whole thing. I've had some younger men have some issues where they needed this, say for pelvic fracture, where they were 20, 30 years old, and they'll have to go through a replacement on occasion. But at 10 years, I generally estimate that about 85% of them plus are still functional and working, but they can break over time. They can wear on the urethra over time, where you get something called atrophy, where it doesn't have as much tissue to squeeze on and therefore doesn't work as well. Can also erode long term, where it wears into the urethra, in which case it'll get infected and has to be removed. And that's not as bad as it sounds. We go in there, we take it out, let things heal, and then typically we can go back in and replace it and get guys back to a good spot. So definitely a hassle, but when you've lived with a lot of pads and a lot of incontinence, it's not a lot to go through to get your life back, essentially, and to get your quality of life, and to get out of pads. Okay. In general, not a lot of cost coverage issues here. I've never, in my recollection, had someone not be able to get one of these because of insurance coverage. It can certainly hit the deductible harder if you have a high deductible. But generally it's medically indicated, and for a lot of them, they have to do with cancer survivorship. So these things are typically covered. All right. A lot of benefits in terms of getting your control back, being able to urinate when you want to. Everything's internal, very high satisfaction. Really, it restores things to normal for guys. And I think we mentioned some of these risks earlier in detail, but here's a slide for y'all to check out later about these things. But I think I touched on all of these things. At the end of the day, very high satisfaction rates and a very enjoyable procedure for me to do for guys, because typically I hear all the time, I should have done that sooner. I wish I would have done that sooner. There's always some hesitance about doing something like this. But if you talk to men who've been through this, they will typically not hesitate to recommend doing it, and they'd recommend it to a friend. All right, quick summary slide, and then we'll get on to some other things here. But essentially, we know this is a side effect of prostate cancer treatments and some other conditions. Fortunately, we live in a time where not only can we, cure these cancers, but we can also treat some of the side effects of treatment. And at the end of the day, I think these are very good options. You certainly don't have to treat this condition if it's happened to you, but it's something that I want you to know there's options for out there. And this website here can go through this in more detail and probably more graphics if you're interested, fixincontinence.com. So take a note of that, and I'll leave this up for just a minute. All right, a few little disclosures here from the FDA on this device. I think we mentioned all these, same thing with AMS 800. On these last slides is what they call their champion program. And this has been a very nice thing for me. I'm not real good about, keeping a list of my patients who want to talk to people, but Boston Scientific has employed men who've been through this as a service to doctors and to patients, where you have an opportunity to talk to men who have been through this. I think it's one thing to listen to a doctor, to go get six opinions on something like this and hear it from our standpoint. It's a whole nother thing to talk to somebody who's been through this. And I think it's very helpful, whether it's ED or male stress incontinence, to talk to men who've been there. This is a nice program. You kind of see some testimonials here, but at the end of the day, they've got a lot of champions that across the country that'll come talk at meetings when they do in-person meetings, but they also set you up with these people for any of our patients who are kind of interested in talking to someone who's been through it. And they match these people in some different ways. They can match you by health conditions, military status, relationship status, things you're interested in, previous treatments, all sorts of things. And so you can get matched up with, people who are very much like you. They can even kind of do it, really it's quite flexible, meaning if you work nights, you can get set up with somebody who probably works nights or somebody who's available during the times that you're awake. So, but I find this to be very helpful. Just want to let everybody know this is an option out there. And I think it's very helpful to talk to men who've been through this. Very likely you've had the same thoughts, the same feelings, the same frustrations, the same fears. And so I think it's a lot better to, kind of hear that from a patient sometimes who's been in your shoes, rather than a doctor who takes care of people on the other end. All right, these are just the references. You guys probably don't need to look a lot at this, but this will be on the recording if you want to go fact check anything, but everything was annotated and references in there, but quite a few references, okay? All right, I think our next screen is going to say questions. This is our last slide, so I'm gonna stop here, leave this screen up, and I believe that